First of all, could I welcome you to this symposium, which is titled Tackling Secondhand Smoke and Life Course Approach. I'll just introduce myself first of all. I'm Heather Thompson. I'm a Health Improvement Manager working in the Department of Public Health at Leeds City Council in the UK, so not too far from here. I've worked in the field of tobacco control for the last 17 years, and during that time I've had the pleasure of working with a number of people who I spot in the audience today and who are presenting. I'd also like to introduce Rumana Hook, if you want to introduce yourself, Rumana.
Thank you. I'm Rumana Hook from Bangladesh. I work as a faculty in Department of Economics, Dhaka University. I also lead a local research NGO called ARC Foundation.
Okay, thank you. So I'm sure you don't need me to outline the harmful effects of tobacco and the devastating and negative effects that it has on the life of both smokers and non-smokers, and we'll certainly be hearing about that in the presentations today. But on a positive note, during the last 20 years, we've seen a remarkable amount of progress in tackling tobacco, both here in the United Kingdom and across the world, and certainly it's good to see so many countries taking on the big tobacco industries. Certainly during the last 10 years, we've seen more and more countries starting to adopt smoke-free legislation and smoke-free policies. So we've seen this across work and public places. So this is starting to offer some protection from secondhand smoke for people who don't smoke. And in addition to addressing a highly important health and safety issue, we've certainly seen the introduction of smoke-free laws has started to denormalise smoking. And in the UK, as a direct impact, we've started to see our smoking rates amongst young people dropping as smoking becomes denormalised. We've still got a long way to go, but it's good to see that's on a downward spiral now. And it's predicted that they will continue to fall, as we've seen in places like California, who've had long-term smoke-free legislation and law. But smoke-free laws only go so far, and they certainly don't protect people in homes and in cars. So this is what we're going to have a look at today. And we certainly know that smoke-free homes affects the most vulnerable, thinking about particularly children, not just in the short term, on the short-term health effect, but as a precursor to longer-term conditions. So what we're going to do in the presentation, we're going to look at a life course approach, particularly looking at working with pregnant women and also with children. And we hope you'll gain some valuable insight into the extent of the problem, the associated risks, and some consideration of some innovative approaches that have been taken to tackle the issue. So I'll ask you to note down any questions that you might have, and we'll do a question and answer session at the end of the presentations. So without any further ado, could I invite our first presenter, Sian Rees, to the floor to present her analysis of the prevalence of secondhand smoke exposure during pregnancy in low and middle income countries. Thank you, Sian.
Thank you. Thank you, Heather. My name's Sian Rees. I'm an academic clinical fellow in primary care based at the University of York in the Department of Health Sciences. I'd like to take the opportunity today to present to you this piece of research that we've been conducting as part of my fellowship. And basically the research aims to describe the prevalence and magnitude of exposure to secondhand smoke during pregnancy in 30 low and middle income countries using a secondary analysis of demographic and health surveys. So very briefly, I'm sure you're all aware, but I'll begin by just talking a little bit about the implications of secondhand smoke exposure during pregnancy. And then I'll go on to describe the aims, objectives, and the methods behind this piece of research, our initial findings and baseline characteristics for the participants in the study, and some of the limitations and implications for this piece of research, and then on to the main conclusions. So, as we all know, the harmful effects of active smoking during pregnancy by mothers is numerous and well known and documented very well in the literature, and includes outcomes such as placental abruption, stillbirth, low birth weight, and we've also seen that the harmful effects can last into childhood and even into adulthood from the effects such as childhood cancers and congenital abnormalities. But there is a growing body of research that is looking at the effects of secondhand smoke in pregnancy. And what it's finding is that there are very similar adverse maternal and fetal outcomes as a result of exposure to secondhand smoke in pregnancy. Most notably, the research highlights that exposure to secondhand smoke in pregnancy increases the risk of stillbirth, congenital abnormalities, and low birth weight, with odds ratios of 1.23, 1.13, and 1.32 respectively. Despite this growing body of evidence, there still remains a lack of information, however, on the global prevalence and the magnitude of secondhand smoke exposure in pregnancy. And this led us to question whether there's actually a greater public health problem here globally than what we've previously perhaps recognised or proportionally addressed with public health interventions. So in order to address this sort of research gap, we decided to conduct a secondary analysis of demographic and health surveys data. For those of you not aware, the Demographic and Health Service Programme is a programme of the Department for International, so it's the Agency for International Development by the United States. And what they do is conduct cross-sectional, nationally representative household surveys looking at populations and their health. And they've just completed their latest 5-year surveys, which use the Phase 6 questionnaire. And the Phase 6 questionnaire was the first questionnaire to include question 101, which asked participants to determine their exposure to secondhand smoke in the home, and asked them to categorise that based on frequency. So it gives them the options of no exposure at all, monthly exposure, weekly exposure, and then daily exposure. So we plan to take all of this information from the countries that had this information available, create a single database in Stata. The demographic health surveys are designed to conduct analyses at a regional level, so you have to weight any nationally representative samples. So we've done that according to their instructions, and we've excluded any countries that had an insufficient response rate to question 101. And then we plan to conduct a regression analysis looking for any associations between the magnitude of exposure and any baseline or baseline characteristics and demographics. So our preliminary results, we've taken the Phase 6 questionnaire, which looks at data from 2008 to 2013. We've managed to include 30 low and middle income countries, which has generated just over 37,000 pregnant women. There weren't actually any countries that didn't have an insufficient response rate. All of the countries had greater than 95% response rates for that question, so we were quite lucky on that front. So this is the sort of the basic results that we've pulled from the data. So we have here the prevalence of exposure to secondhand smoke in pregnancy in the 13 countries included in the study. As you can see, Indonesia has the highest rates of exposure to secondhand smoke, with Nigeria being at the lowest. What we've done is, in the dark green bar, this sort of shows women that are exposed on a daily basis to secondhand smoke while they're pregnant. And then we've amalgamated those that are exposed on a weekly and a monthly basis in the lighter green bars. What was most striking to us at first glance at these results was actually, for most countries, for women who are exposed to smoke during pregnancy, they're exposed on a daily basis. It's actually quite a significant problem in these countries. We then decided to look at these results in comparison to the background smoking prevalence in men and women. And as you can see, we know that smoking rates in women in these countries are quite low, but with a few anomalies aside, there is a general trend that with higher smoking prevalence in men in these countries, there tends to be higher exposure to secondhand smoke during pregnancy, given that it's thought to be that it's the males in the household that are doing the smoking. So obviously we have a vast data set here. So we've started to look at some of the demographics of the pregnant women that are included in this study, and obviously there's a lot of data to go through. So we've just taken a few excerpts from the countries, taking some of the highest prevalence and the lowest prevalence. Generally, what we've found on sort of first look through the data is that there does seem to be already significant positive correlations between pregnant women with no education or the lowest levels of education and pregnant women who are in the lowest socioeconomic groups and exposure to secondhand smoke. And that's the pregnant women themselves, not the people doing the smoking. And we found that across the board in those with the highest prevalence rates and the lowest prevalence rates and all those in between. And that's even comparing non-smokers with passive smokers and not just non-smokers with smokers as well. This highlights to us that there are already, even from sort of first looking through the data, areas where there might be gaps where public health intervention may be required. We already know that interventions such as trying to introduce voluntary smoking bans at home work, but they only tend to work for women where they have higher educational levels, and we can see that there's already that positive association. So there's areas for intervention already showing. I've talked through the prevalence of exposure to secondhand smoke, and I've talked through active smoking rates in men and women, but I just wanted to highlight that this is the most recent global study of prevalence of active smoking during pregnancy itself. And as you can see, this is by WHO region, the rates are actually quite low. The highest is 3.5 in the Western Pacific, and that's still lower than the prevalence of exposure to secondhand smoke in Nigeria, which is the country with the lowest prevalence of passive smoking. So we're looking at a really significant problem here when we're looking at pregnant women as a specific group. So the main limitations for this study, as you can imagine, is the self-reporting of exposure to secondhand smoke. There's lots of literature, qualitative literature, that looks at how people respond to that question, and generally the consensus is it's likely to be underreported. So the prevalences that we're looking at here, although they're high, are probably underreported, but we've obviously got quite a large data set from lots of different countries where lots of variables from within those countries might play a part. We're also obviously doing a secondary analysis reliant on the DHS programme for their data collection methods. But largely what we're quite excited by is the implication for these findings. So as I've already shown, in low and middle income countries, the prevalence of exposure to secondhand smoke in pregnancy is significantly higher, particularly for some countries, than rates of active smoking in pregnancy, meaning that there's almost certainly a higher attributable burden and population attributable fraction for poorer outcomes that we discussed at the beginning of the presentation, despite there being a higher odds ratio for those outcomes in smoking. So what I mean to say about that is, at a population level, the burden of secondhand smoke in pregnancy is likely to be significantly higher than for active smoking in pregnancy. And despite all of that, what we are seeing is that in some countries, the focus does tend to be on stopping people from smoking during pregnancy or targeting smoking in public places. So we're kind of highlighting a group here which are particularly vulnerable, and we have the evidence to show now that they are being exposed at quite a high level. So just in conclusion, this, from what we feel that is the first estimation of the true global prevalence and magnitude of secondhand smoke exposure and looking at those associated characteristics. We're still rating the details of the regression analysis to look at the significance of some of those associations, but I think we're already looking and finding that there are areas for further research and public health intervention in some of these countries. I talked about some of the limitations of self-reporting of secondhand smoke exposure, but I know that some of the colleagues are going to talk about the use of cotinine as a way of objectively measuring exposure to secondhand smoke as a way of improving the reliability of those results. I'd like to thank Cameron and some of my other colleagues at the University of York and the National Cancer Institute in Washington for working with me on this project. Cameron's been the driving force behind this and the brains behind it, so I've not done this alone. These are my references, and I'd just like to thank you for having the opportunity to speak today.
Thank you, Sian. So I'd like now to call Kath Jackson for her presentation on why do men smoke in the home, looking at a qualitative investigation with pregnant women, their husbands and family members.
Great, thank you. Yes, hello everybody. I'm going to tell you about a qualitative interview study. We completed this earlier this year, and it was looking at why men smoke in the home in Bangladesh and India. And it was part of a much larger project called the Impress project. Okay. This one? Oh yeah, thank you. And so the aim of the Impress project was to design, deliver and evaluate a multi-component intervention to reduce exposure to secondhand smoking in pregnant women. Gosh, that's a mouthful. The interviews were the first phase of that project, and we also did a review of literature, and we looked at behaviour change techniques, which Mukesh is going to talk about in the next presentation. And those three steps together informed the design and delivery of the intervention that's currently being tested in the pilot trial. And the Impress project is taking place in Comilla in Bangladesh and Bangalore in India, and it's set within community clinics and antenatal clinics. So here then is the aim of the interview study. We wanted to explore knowledge, views and experiences of secondhand smoke exposure in the home, and within that, look at the barriers and facilitators to achieving a smoke-free home for pregnant women. A second aim was to seek feedback on some of the materials that we drafted for the intervention. I'm going to focus on the first aim today. Gosh, I'm really not good at this. Okay, so we interviewed 31 people in 33 in Camilla, 31 in Bangalore. We spoke to pregnant women, their husbands and their family members. And the family members tended to be the mothers or mothers-in-law who had attended the clinics with the pregnant woman. We achieved a nice mix of women whose husband still smoked in the home, as well as women whose husband had no longer smoked in the home. But we struggled to find husbands themselves who no longer smoked in the home. So we only spoke to 3 of those men. We used a type of thematic analysis, which is called framework analysis, to analyse our interview data. And these are the themes that capture the views and experiences of our participants. I'll give you a moment to look at those, and then I'm going to talk through some of them in more detail. Okay, so what did we learn about why the husbands smoke in the home? There were 2 groups of reasons: the advantages of smoking inside and the disadvantages of smoking outside. We heard from a lot of men and women that the men like to come home from work and to relax and smoke in the comfort of their own home, often sat in front of the television with their children, having a cup of tea. Sometimes they smoked in bed just before falling asleep, and their wife would be asleep next to them. Some of the women and the family members believed their husbands smoked at the home because they were very highly addicted to smoking. And some of the men told us that prior to taking part in this interview, they had no idea that their smoking was risky to their pregnant wife and their unborn baby. The greatest disadvantage of smoking outside was the fear of being seen, particularly by the parents of the husband, because often they believed the parents didn't know that they smoked. Other reasons were the cold, snakes and insects, feeling safe outside the compound at night, and also being fined for being outside after 10 o'clock, or being fined for smoking in a public place. And here's just a couple of 3 quotes illustrating those views. So throughout this talk, the quotes in green are from the husbands, purple from the pregnant women, and there's some grey quotes later from family members. So we also learnt about why husbands no longer smoke in the home, and the key reason for this was the influence of other people, particularly children. And there's a quote there from one of the husbands who told us that he stopped smoking in the home because his daughter kept breaking his cigarettes. Some of the women believed that their husbands were now smoking outside because they were aware of the smell of smoke made the wife feel nauseous now she was pregnant. And a few people thought that because the husband's mum had asked him to smoke outside, that was why he was doing that. And actually, there was a common view that it was much better if more people in the family asked the husband to smoke outside. That was more powerful. Of the 3 men that we interviewed who no longer smoked inside, 2 of them said that this was because they now understood the risks to their wife and to their unborn baby. And again, there's a quote there. What were people's levels of knowledge? Well, most people understood that smoking was risky to the smoker himself. There's considerably less understanding of the risks to the women and also to the unborn baby and children. So some of the women and their family members understood that smoking was risky to the pregnant woman's health. I think only one man who continued to smoke at home said he realised that it was risky for his wife's health, but he couldn't say why. Whereas the women and the family members talked about having a cough and struggling to breathe and feeling nauseous. There was much less understanding of the risks to the unborn baby. None of the men who smoked at home said that they knew of those risks or would understand those risks, and a very small number of the women and family members could talk about that. And they mainly talked about the impact on the babies, on the fetus's breathing. And nobody when we asked people, did they understand the concept of a safe distance, nobody understood what that was. People tended to get their information from the television, although some of the men told us that they didn't believe the messages from the TV. There's some other sources there as well. Interestingly, there was very little mention of learning about secondhand smoke exposure from health professionals. Okay, so how did our participants react to the husband smoking in the home? The pregnant women unanimously told us they disliked the smell. It made them feel nauseous. Most of them told us that they repeatedly asked their husband to smoke outside and away from the children and from her. And sometimes the husbands would respond briefly, smoke outside for a while, but then they soon started smoking inside again. This led the women to feel fed up and to stop asking. And then actually the men concurred. They acknowledged that this was the case. And some of the women, a minority of women, said that they were frightened to ask their husband to smoke outside because they thought it would make him angry. How did the family members react? Well, as I said earlier, there was kind of a common perception amongst the husbands that their parents didn't know that they smoked because they hadn't seen them do so. I think their wives often suggested that the parents did know actually, but they maybe pretended not to know, or they just turned a blind eye. And this was because either the father or father-in-law smoked himself in the home. They perhaps felt that their son was stressed and so needed to smoke in the home, or they were reluctant to ask him because he may be angry. For those who had asked, it seemed that actually the husbands quite often ignored their requests to smoke outside as well. So what would help? Well, there were two clear ideas for strategies to help husbands stop smoking in the home. The influence of other people's requests, and particularly the influence of children asking their dad to smoke outside. There was a common view that the husband most respected his mother's opinion or both his parents' opinion, and so perhaps those, if their parents would ask him, then that could work, although I guess in the previous slide it suggests it might not work. And so there were mixed views on this as a strategy because I guess they'd been tried before and perhaps hadn't been successful. The other approach would be to educate the husband on the risks of his smoking. And the women were clear that this needed to be about the risks to the unborn baby and the children, because the women felt they'd asked them lots of times not to smoke near them as a pregnant woman, and that hadn't worked. But it would be the impact of understanding about the risks to the children that would make a difference, and the unborn baby. And the men concurred with that. They said yes, they thought that would motivate them to stop smoking in the home. The other message was that the education needed to come from somebody who was seen as professional. So some ideas for that were a researcher from the university or a health professional, rather than asking the woman herself to deliver that information to her husband. Okay, so in conclusion, we identified a clear lack of knowledge about the risk of exposure to secondhand smoke, a sense of helplessness amongst the women in terms of asking the husband to smoke outside. They felt slightly unsupported by family members and thought it would be useful if other people were also requesting the husband to smoke outside. And of course, all of this is set within sort of social and cultural norms around gender relationships. And the other key finding was that there was little health professional input, but this was seen as potentially very useful. So all of this fed into the intervention, and I guess we made a few changes on the back of these interviews. An example would be that the booklet that women now receive, it's very clear about engaging other family members in working together to negotiate with the husband to smoke outside. And I'll stop there. Thank you.
Thank you, Kath. So following on from that, we're going to now look at some interventions to reduce home exposure to secondhand smoke. So looking at the findings of a systematic survey, a modified Delphi survey. And so I invite Mukesh Durrani to take centre stage.
Okay, thank you very much, Kath, for giving presentation on impressive study introduction. And in our last group dinner, it was decided that if I whiz through my slides quickly, then in spare time, Kath is going to sing. So I'm going to do that. I'm going to pass through very. So, okay, I'm going to take you through with the systematic review that we carried out and a modified Delphi survey to find out what is happening and what type of interventions have been used and what experts in this area think about. Modified Delphi survey was carried out by a colleague of ours in India with Kamran. Sorry. Right, left. Yep, sorry. Yeah. Okay, so the main objectives were to identify interventions that were used among pregnant women that influence a reduction in their secondhand smoke, and also to evaluate those interventions as presented for their feasibility, generalizability, and scalability. And for the Delphi survey, it was to develop experts' consensus on BCIs. So for systematic review, we used a number of databases were searched, and as you see on this, Medline, PsycInfo, Sinhal, and other databases that we can think of may be useful for identifying relevant literature were searched. And, come on. Yep. And inclusion criteria were the studies that involved pregnant women as study subjects, and it was home-based exposure. Sorry, it's an error. It's a home-based exposure to women rather than outdoor exposure to smoking. And those studies who employ rather better methodologically is epidemiological studies of randomized controlled trial or quasi-intervention designs. And because of the lack of resources, we didn't have much time. So we restricted ourselves to English language. And exclusion criteria were if these interventions were used to reduce exposure among children or other family members. So using PICO criteria, so again, going through same thing. So comparison was no interventions and outcomes that we were looking at. Either it was a number of cigarette smoke reduced in women's present, people quitting. We get information about quit rates, reduction in an objective measure like cotinine or CO levels or nicotine, or if they were measured, or increase in awareness about secondhand smoke harms in study population. So this was the flow chart. Over 3,000 studies were searched, or found out, and majority of them did not use any intervention, were excluded. So at the end, we reviewed 31 full text articles, and of those, 6 were selected for qualitative survey. Because of the wide variation in the outcomes assessed, we could not do any meta-analysis. Of those 31 studies, majority were rejected because either they were systematic reviews themselves or secondary publications, primary being included in this survey, or pregnant women were not the study subjects, and they were not experimental design or other languages or something else. Oops. Come on. Yep. So, sorry. So these were the outcomes, and as Kath was saying in her qualitative survey, what she found about knowledge and other things. So these were the few outcomes that were assessed. Either people, they assessed whether their intervention were helpful in enhancing study subjects and pregnant women's knowledge about harmful components, if disease that are involved with secondhand smoke, or benefits of reducing secondhand smoke, any harms by various study, and perceived susceptibility. And they also managed to also assess pre and post secondhand smoke in study by Lee, and also taking actions of smoking, actions against smoking at home. Reduce exposure to secondhand smoke, direct reduction. I mean, most of them, I'll come back to that. The majority of them were self-reported. And because of their qualitative behavioral change techniques were used, so they were also assessing stages of change and reduction in smoking. Only one study was able to assess the health outcomes: low birth weight, very low birth weight, preterm and very preterm birth rates. And of those, we find out that very low birth weight and very preterm birth, that is under 30 weeks of gestation, were statistically significant in that particular study carried out in the US. So we also assessed, as I mentioned, one of the objectives was to assess whether these interventions were described using any particular methodology. So there's a nice checklist by the workshop that was carried out by Workshop for Intervention Development and Evaluation Research. So they carried out to present that how these interventions should be reported. And below is the criteria that they used. So if you can see that from 1 to 8, whether characteristics of those who are delivering interventions, if they are mentioned, characteristics of recipients, study settings, mode of delivery, intensity, duration, fidelity, and detailed descriptions of intervention. So if you can see on the left-hand corner that for the intervention group, majority of them more or less adhere to these guidelines, though guidelines were published later, but people were mindful. These are very common things. So people were mindful of these things, and they adhered to that. Apart from in control group, where majority of them did not have control group, 2 of the studies, or did not describe the description of the control group at all. Some of them mentioned about how they developed their interventions, and also referred to their manuals if they were, and few of them were available, but though the studies were published in English, the material were in Chinese. So this is more or less from the wider criteria. And for scalability and generalizability and feasibility, we used a couple of frameworks that are presented by Bonnell in 2006 and Millat in 2013. For scalability, because it encompasses generalizability is one of the criteria to assess scalability. So we assessed it, and apart from one study that was carried out in, I think, China, Lok and Lam, way back in 2005, it was a randomized controlled trial, which we can see that it was scalable, and obviously because if it's scalable, the subsets were generalizable and feasible, so they were there. But majority were feasible, but generalizability, because of the lack of a study population, or because of the non-random selection of the sample, we could not assess whether these were generalizable. So now I'm coming back to the Delphi survey. So it was a modified technique that was used, and opposed to a standard one. And in round 1, experts were sent a list of BCIs and asked them to anonymously rank them. And after that, once that was received, based on that feedback, we sent these list of BCIs to them again for another round of feedback. Yep. So there were nearly 30 experts in first round, and 57% of those responded. And of these 17 in second round, 88% responded. Either it will flick to, or, yeah, good. So this was the method that I just mentioned. So analysis showed Kendall's W score was very low in the first round, and in second round it improved a bit, but it's still low. So we are thinking of going for a third round to improve Kendall's W score. So these were the BCIs that came up from the experts' opinion. And they are mentioned according to their rank on the left-hand corner. Yep. So in conclusion, what we find out from the systematic review, that there is a paucity of literature, especially if we are thinking of South Asia. Sean already presented that there were a number of countries, Pakistan or Bangladesh, they had one of the high rates of secondhand smoke in pregnant women, but there was none of the literature of showing any intervention carried out in this area. And of these studies that we used in systematic review, only one study in China by Lee that taken into account women's view, pregnant women's view about how to develop intervention or what intervention would they like. None of the other studies carried out a similar thing. And all these studies were health facility based. All the pregnant women were selected from there. And they used some behavioral change techniques of trans-theoretical model or health belief model. All the outcomes were self-reported. And knowledge of mothers assessed and enhanced. As we can see, these interventions were quite useful in doing that. And if physicians or nurses interviews were used, but they did give advice, and it was quite useful. Lab-based, the objective measures like cotinine or carbon monoxide, they were assessed in a couple of studies, but the data was not presented, and family members' knowledge and attitude was not assessed. And only one study which we found may be scalable. So the final conclusion is there is a need, this is what IMPRESS study is going to do, is to develop an intervention and test it that takes into account of end users' views, experts' opinion, and also assesses the scalability. Thank you.
Thank you, Mukesh. I'd now like to invite Cameron to take the stage, who's going to talk about secondhand smoke exposure in children with low-income countries who have smoke-free laws. And this is around a school-based survey that was conducted in Bangladesh.
Thank you, Heather. Good morning. I don't know whether you've noticed there is a theme to this symposium. So we've been talking about secondhand smoking, of course, but it's a life course approach. So the first three presentations that you've seen were about pregnancy. And what happens after pregnancy? Children. So we're going to focus on children. And I'm going to present some data that is guaranteed to be mind-blowing. So if you're planning to check your emails or take a snooze, that's absolutely fine. But when we come to the results, I would like you to pay particular attention because they are frankly, they blew our minds because they were just so amazing. So secondhand smoking exposure in children in a low-income country with smoke-free laws, and that's Bangladesh we're talking about. So this is a school-based survey in Bangladesh, and I was privileged to be part of a very, very good team in Bangladesh that did this survey. So I'll talk a little bit about the smoking bans and secondhand smoke exposure, then I'll present the findings, and then we'll have some conclusions. So I think probably you're all aware of this phenomena of secondhand smoke, and 600,000 people die every year because of secondhand smoke, which I think a lot of us believe is an underestimate. So we are focusing on children. That makes up of 28% of that burden of disease, and we're not even counting children who grew up to become smokers themselves, because there's evidence that if your parents or you happen to be in a smoky environment or brought up in a smoky environment, that you're more likely to become smokers. So this 28% is just about their direct effect on their health from secondhand smoke, not to count what happens afterwards. One of the fantastic interventions in tobacco control, in addition to the tax increase, is the smoke-free policies. And I think we all agree on that. And no smoking bans have been very, very successful. But most of the data is from developed countries, as I'll show you. So this is the data from Canada. It's based on self-reported surveys. And as you can see, that ever since the smoking bans came in, and this is data tracking from 2003 to 2014, there has been a constant decline, and we're looking at, particularly at the children, at how many children are exposed to secondhand smoke at home. So I think we all agree that smoke-free laws have not only impacted smoking exposure in public places, but also at homes. Now, this is very interesting data. So this is data from UK, and this data measures the percentage with undetectable cotinine. And I think most of you are aware that cotinine is a marker for secondhand smoke exposure. These are the years. And as we know, in England, the ban on smoking came in 2007. So this is the percentage of people who were using, percent of children who have undetectable cotinine. And as you can see that it was quite a lot of children who were with detectable cotinine. So it actually went up quite significantly in England. And this is including all children. And these two are, so this is children who are living in no smoking homes and children who are living in smoking homes. But nevertheless, for all children, at the end of 2012, most children had no cotinine in their blood. So this is about 70% children had no cotinine in their blood. So this is fantastic. And when you look at the clinical picture, again, the outcomes prove themselves that if you look at the preterm birth, you look at the low birth weight, and you look at asthma admissions, I think all of these were significant difference was made because of smoke-free laws. So I think I don't need to labor this point, but I think we all agree that smoke-free laws have been one of the best interventions. But what is happening in low and middle income countries? This is what our focus, and particularly Bangladesh, because that's where we did our study. Is the picture similar in Bangladesh or not? And Bangladesh is signatory to FCTC, and Bangladesh has got a Tobacco Control Act, which has been strengthened in 2012. So they have strong smoke-free laws, probably as strong as England. But the smoking prevalence is clearly very high, and 44% people, 44.7% males smoke, adult males smoke in Bangladesh. So there hasn't been any data in Bangladesh that's based on objective assessment of secondhand smoking exposure. This is some of the data from the ITC study that has looked at percentage of smokers who noticed smoking in various venues at last visit. And there has been some change in 1 year, but I don't think most of this change is probably not that significant. So in children, we don't have any data. So the objective of our survey was to understand the distribution and determinants of secondhand smoke exposure in children in Bangladesh. And we had a randomized control trial, and this was part of the baseline study. So a cross-sectional survey was conducted in children in 2 semi-urban areas in Bangladesh, in Dhaka, between March and May 2015, included 12 primary schools and 481 primary school children. So we collected quite a lot of data, and the data that we were particularly interested in was smokers living in the household, smoking restrictions, exposure inside and outside homes, and also some socio-demographic factors, but more importantly, the levels of cotinine. This is the first time, I think, in Bangladesh and probably in many low and middle countries that anybody has measured cotinine levels in children. And we took this figure as exposure to secondhand smoke. So anything above 1 nanograms per deciliter is going to be positive for secondhand smoke. So this is how we collected data. As you can see, cotinine levels were measured through a saliva sample, and saliva samples were taken in schools from children. And then we analyzed it using statistical software. So this is where I said the results are mind-blowing. So the exposure of children to secondhand smoke in Bangladesh, in our survey in Dhaka, was 95%. And I think we all thought it would be high, but I think none of us thought that it will be as high as 95%. So let me just repeat. 95% of children in our survey sample were positive for cotinine, and they had secondhand smoke exposure. And the average cotinine levels was 0.36 nanograms per milliliter. So we also looked at some of the other variables and looked at where are there any associations with other variables. So one of the things is, obviously, if you live with a smoker, you are more likely to be exposed to secondhand smoke. And clearly there were 44% children who were living with smokers. Smoking restrictions, again, complete and partial smoking restrictions. So only 21% houses have complete smoking restrictions. And then if there is any other smoking exposure outside homes and cars, and 87% of kids said that yes, they were exposed to secondhand smoke outside homes and cars. So let me just remind you, this is a country with smoke-free laws, and 87% kids are saying that we've been exposed to secondhand smoke outside homes, public transport, streets, shops, so on and so forth. So we then did an analysis of some of the explanatory variables of cotinine levels, and I think you wouldn't be surprised that one of the things that came up was maternal education. I think whatever you look in children, it almost always correlates with maternal education. So this is no surprise that the cotinine levels were actually, so the more educated the women are, or mothers are, the less likely their kids have got cotinine exposure. And of course, socioeconomic status is also another variable. That didn't surprise us at all. And then number of tobacco selling shops in the neighborhood was an interesting finding, I think. So it was strongly correlated with the fact that these kids had higher cotinine levels. And then, of course, living with smokers. If you're living with a smoker, you're more likely to be exposed. So we found that there was a very high prevalence of secondhand smoke exposure in our sample size in Dhaka and children. The cotinine levels were higher if you live with smoker versus non-smokers. 56% were exposed to secondhand smoke, but they were not living with smokers. So this is also important. Again, goes back to the point that 88% reported being exposed outside homes and cars. So I know it's not really a fair comparison, but just for the argument's sake, we did compare the figures with England. In England, in 2012, 28% live with smoking parents. In Bangladesh, 44%. And 87% of homes are now smoke-free in England. And we also looked at number of children exposed at the moment. So only 32% of children are exposed to secondhand smoke. But in Bangladesh, as we've seen, 95% in Bangladesh are exposed to secondhand smoke. So when we actually, because these results were analyzed in the UK, samples were analyzed in the UK, and we actually were surprised, obviously, and we spoke to the lab, and we said, well, are these results valid? And of course they were valid, and they said, we are not surprised, because these are the figures we used to see in 1970s or early 1980s. So this is not a surprise, and these were the figures actually. So I don't think we should wait for 30 years for these figures to come down to this level. I think we should try to do this within 2-3 years, 4 or 5 years maybe. And of course, the mean cotinine levels are also much lower in kids in the UK than compared to kids in Bangladesh. So in conclusion, remember, this is an urban and peri-urban area, so I think the situation in rural areas might be different. So I'm not going to generalize to all Bangladesh. But I think, again, to repeat my findings, 95% children are exposed to secondhand smoke. Only 21% reported complete smoking restrictions in homes and cars. So of course, making homes and cars smoke-free will help. But remember, this is not all exposure. It's from homes and cars. And therefore, robust implementation of smoking bans in public places is needed immediately. And I would like to thank all my colleagues who helped in this study and Medical Research Council for funding this study. Thank you.
Thank you, Cameron. Certainly some somewhat shocking findings within that survey, which I must admit have quite surprised me. So I'd like to now invite Rumana Hook from Bangladesh to talk about an intervention that's been delivered with schools, which has been looking at methods to work with children to help protect them from secondhand smoke exposure. Thank you, Rumana.
Thank you. I would like to thank all the previous presenters for keeping their time so well. So I think I can take 1 or 2 minutes more. Trust me, I will not take. As Dr. Kamran said, our session today is how we can ensure that our children are tackled quite early in their age so that they can have a better health outcome at later stage. Considering that, we developed an intervention, and I'm going to present that here. The title of our presentation is What Can Be Done in Schools to Protect Children from Secondhand Smoke Exposure. On behalf of my team, I'm presenting today. I will briefly talk about the background of the study, the objectives, and I will also talk about the methods we used, the results, and conclusion. Like many other developing countries in Bangladesh, exposure to secondhand smoke is a serious threat to children. We know that the public places and workplaces are smoke-free by law, but obviously the implementation of the law is still weak. We have achieved a lot, but still a long way to go, which was emphasized in the previous presentation. We have very limited national or local campaign or health promotion programs to protect children from secondhand smoke exposure at home. We have legislation to protect them from the public places, from bars, cars, but at home, there is very little measures have been taken to protect them. And also in Bangladesh, 44% of the men smoke, and the power structure of the family is that it's quite male dominant, and if the husband smokes inside home, as Kath also presented, it's really a challenge to ask him to smoke outside home. We found in our previous study that most households, at around 55.5%, have at least one smoker, and smoking inside home is also very common in front of the children. We found that 40% of the smokers smoke in front of children. In our previous presentation, Dr. Kamran showed that 95% children are exposed to secondhand smoke. Against this background, we developed a school-based smoke-free intervention to support the families in implementing the smoke-free homes in Bangladesh, and we gathered some preliminary evidence for this, so I will present a few of the findings today. The objective of the study was to examine how effective these smoke-free homes is in reducing children's exposure to secondhand smoke, and also to see if the intervention improves their lung health, their general quality of life, their school attendance, and school performance. The study was conducted in Dhaka district and 2 peri-urban areas in Savar and Mirpur. Already mentioned that it's 12 schools we recruited and 481 students were assessed for the study. And it was a 2-arm pilot cluster randomized control trial where the baseline has already been presented. I will do the baseline and the first follow-up. So how we included the schools? Those followed the national curriculum. We only included those. And schools have to have no smoking policy. And all schools said that the teachers of the year 5 grade and all other teachers also, non-smokers. So we included the children who are studying in year 5, so 5th graders, and who are also self-reported non-smokers. We excluded the schools, obviously those are following some other curriculum, and also those who doesn't have class 5 or only have primary school, because we wanted to follow the children for long, so we ensured that the schools are having primary and secondary schools as well, classes. The children who has some history of domestic violence or some medical condition, we just excluded those. So what the intervention was, this intervention, first we trained the teachers of schools. The teachers were trained on what is secondhand smoke, what are the side effects, and also their roles in the study. This intervention included a flip book which talks about the story of a boy called Bijoy and his exposure of secondhand smoke and how he tackled that at home. We also had a storybook about Bijoy, which also talks about how Bijoy could negotiate with his parents to make his home smoke-free. We also had some quizzes and a word search game. The intervention was for 2 days. So day 1 was a 45-minute session, which the teacher showed the flip book and talked through the Bijoy story, that how Bijoy could make his home smoke-free, though he was exposed to secondhand smoke at the beginning. And also we tried to do some role play so the children get more empowered and understands how they can negotiate with their parents to make their home smoke-free. During the second day, it was reiterating the same messages. The students again read the storybook, and also they played the word search game, found out the words to understand what the intervention is. We collected data using self-reported questionnaire. We collected saliva in schools. We also tested their lung function. Also, we collected their absenteeism data, their school performance data from the schools. Also, we asked the student to keep a symptom diary where they have to record 13 respiratory symptoms every day on a daily basis. So this is our flow diagram, which shows that we recruited 12 schools and we divided them into 2 arms, 6 and 6 schools, intervention and control. And in the intervention arm, we have 256 students, and in the control arm, we have 252 students. And we followed them up in month 2, though there were some loss to follow up in the second survey. We tried to make a balance between these 2, intervention and control arm, when we randomized, and this can be shown here. In both arms, intervention and control, the ratio of boys and girls were pretty similar, and the education level of father and the education level of mother, this was also comparable. So we did not find any massive variation between the education of parents or the gender. So this was a balanced distribution between intervention and control group. As already Dr. Kamran showed, that we found that children are exposed to secondhand smoke. So this slide is showing whether there is difference in intervention and control arm. So in the baseline, in the intervention arm, we found that around 93.4% children are exposed, whereas in the first follow-up, after the intervention, this slightly gone down to 92.4%. And in the control arm, again, at the baseline, we found that the 94% children were exposed to secondhand smoke. That also gone down in the control arm in follow-up to 92%. And the mean cotinine level, as mentioned earlier, the overall, it was 0.38 nanogram per ml, Dr. Kamran said. But in the intervention arm, at the baseline, we found that the mean cotinine level was 0.35 4 nanogram per ml, which gone down to 0.30 nanogram ml after the intervention. In control arm, it was 0.38 nanogram per ml during the baseline, and in the first follow-up, it gone down to 0.36 nanogram per ml. So what we found was the difference was not statistically significant, but of course in the right direction. It gone down, but it gone down quite slightly, and there is a very limited difference between intervention and control arm. So our intervention rightly addressed that we have to do something at home, but maybe it is not enough to only protect children at home because they are exposed outside home as well. And the law banning smoking in public places in Bangladesh, that also needs to be strongly implemented. And we also think that we need a definitive trial to study its effectiveness. And we need comprehensive efforts to protect children from secondhand smoke from all sources, from the parents, from lawmakers, from everyone. So a comprehensive, a combined effort from everyone can only protect the children. So we are looking forward to present the other information that we collected, its symptom diary and the absenteeism data, maybe in the next union conference with some more exciting results. So it is the preliminary findings. So what we have done, we thought that it's worth presenting today and showing that how the children are exposed and how vulnerable they are to secondhand smoke. So we need to really design some intervention at really early stage, maybe, as Kat said, from the pregnancy of the mother, and also at different stages so that they have a better health outcome in later life. Thanks.
Thank you to all of our presenters who've whizzed through their presentations in super quick time. So we are at risk of Kath possibly singing. But just summing up, we've had some very thought-provoking presentations today. I'm going to try and read from my notes, which I've been scribbling, and I've been lucky if I can read my own writing, but let's have a go. So we've seen some really thought-provoking presentations today. We've looked at the extent of secondhand smoke exposure of pregnant women and children, particularly in low middle incomes countries, and I think we've certainly seen some shocking results from exposure of children, not just around secondhand smoking in the home, but also outside the home as well from the Bangladesh survey. We've started to explore the types of characteristics of people, particularly in relation to low and middle income countries where secondhand smoke exposure is more prevalent. Kath then explored the lived experience of pregnant women and starting to understand the challenges faced by women of addressing smoking with family members and partners, and the sorts of attitudes and knowledge that will need to be addressed within the development of interventions, both from smokers and the non-smokers' perspective, and how these might inform this. We then considered the available literature with Mukesh's presentation around the effectiveness of secondhand smoke interventions with pregnant women, and I was really pleased to see the inclusion of the Delphi exercise with the introduction of the behaviour change techniques and interventions within that, and really starting to fine-tune those interventions. And then we moved into Cameron's presentation, where we looked at the data around smoke-free secondhand smoke exposure to children in Bangladesh, which, as I say, showed some really quite shocking results. And then Rumana has presented the work with the school-based intervention in Bangladesh and the outcomes of that. Just before we go into questions and answers, just a few of my own reflections on what I've seen this morning is that, having worked in tobacco control for many years, there's been much research around the impact of tobacco on smokers, a lot of research done around that, looking at the harmful effect, looking at effective interventions. So I'm really pleased. We started doing some work around secondhand smoking in the homes probably around about 2005, when we started looking at this within our own work in the UK. So I'm really pleased to see this particular area of work developing, and we can certainly see from the interventions and the presentations today that there is a real need to address exposure to secondhand smoke, particularly around pregnant women and particularly around children who are probably not in a position to be able to take themselves out of those situations where the exposure occurs. The other thing that I'm always heartened to see is, as somebody who part of my role is around about commissioning interventions for tackling various tobacco control initiatives, whether it be smoking or whether it be secondhand smoke. I'm really pleased to see that more and more work is being done around about fine-tuning interventions so we can consider the transferability of interventions. So it's always heartening to see the use of behaviour change techniques and having those described in much greater detail. I think some of the things that we found is that you need to really spend time looking at the context and the audience that you're looking to intervene with and looking to fine-tune, because obviously the sort of behaviour change techniques that we would use in an intervention in the UK are going to be very different from the behaviour change techniques that will be used in an intervention in another country. So I think things like Kath's insight into people's lived experience is very important in laying the foundations in those intervention designs. So it's really nice to see a lot more work being done on really fine-tuning interventions and looking at the sort of behaviour change techniques that you would employ within those interventions. I think the other thing that struck me today is where interventions have got limitations. Because obviously we're doing a lot of work around trying to build intention to change and around about supporting intention to change. But I think certainly the survey that Cameron conducted has also shown that you have to have that infrastructure as well. It's not good enough just to be able to deliver those interventions. You need to have that supportive infrastructure, whether it's environmental changes, whether it's implementation of smoke-free legislation, and more importantly, the enforcement of smoke-free legislation, which is really where I think we do have problems in a lot of countries into how we actually enforce that. And I know certainly, I've been in countries that have got smoke-free legislation and smoke-free laws, but yet I still see smoking on public transport and within restaurants, etc. So we've not fully cracked that one yet, but certainly it's good to see there's movements all the way towards that. So thank you to all of our presenters. So I'd like to open up the floor now to any questions that you may have. We've got lots of questions, that's good. Shall we start with the gentleman at the front here? If you'd like to say, yes, if you'd like to say who you are and who your question is for, please.
I'm Elif Dalı. I'm a pediatric chest physician working in tobacco control from Istanbul, Turkey. I'm really very impressed by this session, and I would like to thank the organizers to putting this together. What has happened is you have presented data from low-income countries, and we have a comparison that was published last month in European Respiratory Journal, looking at the Western data, the developed country data. So when you compare it, the pregnant woman being exposed to passive smoking was 64% in the Western studies. So only 27% of the babies were not exposed to active or passive smoking of the mothers. So that is comparable with low-income countries. So Western countries are not doing much better than that. And what I want to stress on is about how are we going to solve the problem? Are we going to solve the problem by educating children and giving them the responsibility, or shall we do bigger campaigns at community level and involving the fathers who are the real problems in that? And there had been studies in the last 2 years looking at the DNA methylation. If mothers are being exposed to, not even mothers, but grandmothers, if they are exposed to tobacco smoke, the children's DNA are methylated, meaning that their DNA is not changed, but they behave differently, which gives children persistent asthma by the age of 2. So this is extremely important. It is a criminal thing to do. I think what we are being too kind and too soft in our interventions. So my question is to all of the speakers, shall we not be harder hitting to all the community?
Would anybody like to respond to any of our speakers?
No, go on then, Cameron. It's everything. I think all the efforts in the families and the community, and particularly fathers, I think the point was very well made. So I think one of the things that we're trying to do in our study with Liverpool in India and Bangladesh is we're giving 14 levels, actually showing that basically lacquer going from the unborn baby to the father, saying that, hey, I'm looking forward to meeting you and my dad, but you got to stop smoking around my mother because this is getting cotinine into my blood already. So this is kind of getting emotive stuff and getting fathers to, hang on a second, what am I doing here? So this is, we're trying to, latch on to the sort of emotive aspects of things, because of course fathers do also care about their children. And I think as long as they will realize that their behavior is actually influencing their children's outcomes, I think they will make a change. So that's one of the small intervention I think we're trying to test in India in Bangladesh.
Thank you, Dr. Kamran and Dr. Romana. Really, the results of second-hand smoke exposure are very surprising. So first of all, did you compare these results with any of other second-hand smoke exposure in Bangladesh? I happen to be in Bangladesh regularly for conducting smoke-free workshop, empower workshop, and other things. And I definitely share SHS exposure in Bangladesh in all our workshops. But I think this is something which you have in both of these studies. Exposure is 90% plus among children. So any comparison with other studies? Secondly, where cotinine levels were done, whether all the samples were shifted to here, Liverpool, and then they were done. Thirdly, as per Global Youth Tobacco Survey, normally we consider GATS and Global Youth Tobacco Survey as gold standards for informing tobacco use prevalence among adults and children. And in Bangladesh, exposure to secondhand smoke at home in children is 30%, and at workplaces and outside public places, it is 60%, 30% and 60%. When I was in Bangladesh, I was sharing these figures with the people, that in Bangladesh, 60% children in Bangladesh, they are exposed to passive smoking. So now finally, do you recommend, first of all, do you want to recommend your finding to the people who are conducting SHS exposure, that we should undertake cotinine levels rather than just asking as a questionnaire that are you exposed to passive? Because difference is huge. It's a huge difference. So are you going to make some recommendation that CDC should consider cotinine levels to give us actual picture? Because actual burden will help us to design our control policies, to design our behavioral policies. 30%, and here both studies shows 90% secondhand smoke exposure. Thank you.
So I think the third question is very easy to answer. Yes, I think this is what we should do. Cotinine levels is a very, very sensitive and specific measure of exposure to secondhand smoke. So a lot of people will probably be in a room where somebody's been smoking and there's secondhand smoke and thirdhand smoke, but may not notice. But when you check their cotinine levels, then it will be there. So of course, so we didn't find any study, not just in Bangladesh, but actually many low and middle income countries, that detected cotinine levels in children. So this is the first, I think it's the first. If there's any other study, please let me know. And the second thing, that we analyzed the samples in the UK. So there is a lab which is recognized, and they analyzing cotinine levels for the last 30 years. So they're all shipped over.
Thank you very much. This is very eye-opening session. I think there are many new informations which are quite, emerging issues are there. I'm just wondering, because this is a 95% exposure in Bangladesh, as both the studies are saying. I'm just curious to know whether these studies or the results have been shared with the government, or whether the government is also endorsing the same, or do they have any agreement to with the interventions, kind of interventions to explore with other programs? And secondly, is there any convergence program with the other parallel program according to the school health program is related?
Thank you. This is the pilot study that we are doing. Before that, we did a feasibility study. And during that time, we involved WHO and Ministry of Health representative when we were designing the intervention for for the school-based intervention. But of course, as you said, the findings that we are analyzing now, definitely we will share with government. And also we have a Ministry of Health representative here sitting, and Dr. Tahin from Union, he's also here. So these are the platforms we are using now, but once the paper will be published and we will analyze the full data set, definitely we will arrange those communication and use all the platforms to communicate the information to the government.
Okay, thank you.
Could I take the question from the gentleman at the front, and then we'll take your question after that.
Thank you very much. It's a wonderful session. I'm Xiaoling Wei from University of Toronto. I think my question is first, you look at the kids coating level and for smoke-free home. But when I was a kid in China, I remember my school teacher smoked a lot. So we also need to look at smoke-free schools and smoke-free buses, because in the buses, lots of people smoke. I guess I'm not surprised to see you did not detect the difference. And the second thing, we have analyzed the Hong Kong data in Hong Kong for the last 35 years regarding smoke-free laws and regarding the tax hikes. We found that only there was a tax hike over 70% of the price, you would see a deduction of smoking, and then also consecutively you see a deduction about cardiovascular disease hospitalization data. So, but the smoking-free laws was not strong enough to see such a change. So what I'm trying to say that there are so many different kind of social factors and the social interventions we have to really do well there. For example, in Hangzhou in China, they just first get rid of the candle, all the shops selling tobaccos and around the school, because as you find out, that is a very powerful factor as well. So we have to do lots more to really see a change. Thank you.
Thank you. I think that's a very valid point about that layering of interventions and infrastructure to do this. It's not going to be one intervention that's going to really have an impact, but it's the environment, it's about the infrastructure, it's about legislation, as well as interventions to help people, to support them, and to inspire people to think about changing. So I think it's extremely critical that a comprehensive approach to tobacco control is employed rather than trying to do single interventions. The gentleman at the back.
Thank you, Dr. Kamran and Romanappa, for your presentation. It's very alarming. And yes, we have very limited intervention and activities on the secondhand smoke in the home, because this doesn't cover the law. But my question is two things. One, according to the WHO study last 2003 global youth tobacco survey, that showed that 37 youth are exposed in the secondhand smoke. And what you show, it is 95%, very alarming. And so if you do have a study to compare that one, why it is 37 and 95? And another thing, that how you selected the area, the process, those area you selected for the study, how you selected this area, the criteria of the selection of your research area. Thank you.
I can respond to the first part. And then
Sure.
So I think the surveys, the GAT survey and the Global Youth Survey, they're self-reported data. And I think what we're seeing, that self-reported data is an underestimate. And it's a huge underestimate, in fact, particularly in children, because children are, the visibility is sometimes not there. So parents may not voluntarily smoke in front of children, but they smoke in the same room. And as we know that the particles of secondhand smoke stay in the room, not just in the air, but also in the furnishings and in the carpets and everything. So it doesn't go away. So that's why I think we're seeing such a big change.
Selection of the area, we look at some pragmatic factors because this is a pilot trial. And we also consulted with WHO and Ministry of Health to find out that these are the areas where we have lots of slum children going to those schools. And as I mentioned, we only recruited those schools who has the mainstream Bangla medium curriculum, not the English medium. So Mirpur and Savar are the areas we got lots of Bangla medium schools where we can at least recruit those numbers. And it was easy to go there, so all those pragmatic factors. And we worked in those areas earlier for other projects.
Okay, next two quick. Can I take a question from the lady in the white, and then we'll take a question from the gentleman towards the back? Sorry, Mukesh, I'll take yours. Can I take yours afterwards? If you take the lady in the white first of all. You're all jumping up.
Thank you. I want to thank, my name is Kellen from the Center for Tobacco Control in Africa. I want to thank Dr. Kamran and your team for the interesting presentations. And I must also confess that we've been looking at the effects on adults and we've not been, paying attention to children. I just want to make a comment that I think it's high time that we started to look at Article 12 very, very critically and to put in money, because when you look at low and middle income countries, I think awareness is going to be very interesting. And I think I want to see your results later on to see what is the effect when the children start to talk to the parents, when the children even talk to the people in the cars, in the buses, and say, please stop smoking or don't smoke amidst, some people or young people or children like me. So I want to see, or to say that we need to put funding, we need to think about awareness. And when you look at reporting to COP, that is one of the areas that donors and governments are not very interested, but I think it is a key article to think about and to look at and invest in to create more awareness. Thank you.
Thank you. Gentleman about 5 rows back now. Yes.
Thank you. Bill Bellew, Sydney Uni. Thanks very much. Tour de force of research presentations. 3 quick points. In the Pacific, so we do some work in Pacific Island countries and territories, a baseline survey for a campaign, and by the way, here's a plug for Vital Strategies, because if we want to do the awareness work, we already have a suite of ads that deal with exposure to secondhand smoke. Eating Baby Alive is a good one, for example. Baseline data showed that only 23% of the adult population were aware of harms to baby from secondhand smoke. It will be interesting to see what happens in follow-up. Second comment is about what would happen if we had any longitudinal data and we looked at what happens in terms of learning outcomes and employment outcomes, and then they turn into costs to the economy and their data that politicians understand perhaps better than some of the other ones that will appeal to us and to pediatricians. And final comment, we're involved in some work doing some scaling up of Healthy Beginnings. Healthy Beginnings is where nurses come in at 3rd trimester, they come in at 1 month, 3 months, and so on. So you have about 6 interventions in the first year of a child's life. The nurses are not worried exclusively about secondhand smoke. They're interested in immunizations, in breastfeeding, in some physical activity, tummy time, in reduced screen time, and so on. And so the thought about scalability and sustainability is the likelihood that this will be done in an integrated way alongside the other things we need to do for Healthy Beginnings to prevent obesity, for example. And there's another likelihood in developed countries that it won't necessarily be face-to-face, but will be by telephone and by SMS. And so good literature on that. And if you look at motivational interviewing, they'll use the stage of change model very appropriately in different cultures because it's client-centered. But perhaps a simplified version so that it's 3 stages, not 5.
Sorry. To the gentleman.
All right, thank you. My name is Hassan Mohammed. I'm from the Maldives. Just referring to the presentation, the last one on about the children being exposed, that's really an eye-opener and a very disturbing one, especially when we have smoke-free laws in the country and 90% children being exposed. The first question posed was a very interesting one, so I thought I would say something in relation to that as well. All of us, all the countries are signatories to the CRC as well. So the Convention on the Rights of the Child, and I think many countries have enabling local legislation also protecting the children. and the primary responsibility falls on the parents. So exposing them to secondhand smoke, we could say it's a crime. But then again, laws do not go into homes. So I think the only intervention is advocacy, awareness to parents. Since you have already found out in your studies that you're linking the child's performance in school to the exposure, that is a very powerful one. So if you say it touches the child's intelligence, parents can be very concerned. And another intervention in some countries that are doing it is get the child to advocate on the parents. So awareness to the children and empower them and say this is your right. But how you can approach and inform your parents. And also smoke-free home concept. Governments can recognize and give some awards to households, homes, where there will be the leading man or leading woman of the house who's powerful enough to say, okay, in this house nobody smokes. So if you can empower them and make smoke-free homes, these are the types of interventions here. We can say, okay, this is child abuse, you're violating the right, but then government cannot go and penalize the parents and whatever they do with the children. In most cases, we can't. So, yes, it is. But then, how can you, in schools, yes, the principal can be made responsible. But what I'm saying is that smoke-free laws, the tobacco control laws, even we have it, we don't go into the house. It's public places. At home, it's awareness and advocacy. I think that's the best intervention. Thank you.
Thank you. I think just an interesting point, recently in the UK we have introduced a law around banning smoking in cars with children under the age of 18, and I think it's a very difficult law to try and enforce, and I think what we're actually finding now is that it's public approval that's starting to, the shift in social norms is actually starting to enforce those laws rather than any regulated enforcement on that. So I think that shift in public opinion and public approval is going to be really key in supporting what's acceptable and what isn't in the terms of smoking exposure.